All right, we're going to go ahead and get started, and if a few more join us, that would be wonderful. For those of you who don't know me, and somehow I'm not appearing on the screen this time, but my name is Sherry Mathis, and I'm with the ALS Association, and I want to welcome you to this month's ALS Learning Hour. I'm so happy you could join us. Before our speaker gets started today, I just want to go over a few reminders. Um, you can add questions within the chat or the question and answers feature anytime during today's presentation. And we will do our best to address as many as possible within our time together. So I'll be watching those and pulling those forward as Katie finishes her presentation today. This presentation is being recorded and will be sent to those who registered later this week, along with some additional resources on this topic. And then as usual, when you leave the webinar today, our 4-question survey is going to pop up for you to complete, and we really appreciate your input. Your feedback matters. It helps inform what else we might plan as for future months based on what it is that you guys find most helpful in the information that you're looking for. So with that, I want to get started today and introduce you to our speaker. Our speaker today is Katie Prigel Sharp. And Katie has been a social worker for more than 20 years. She currently serves as the Director of Social Services and Palliative Care for Ascend Hospice and Palliative Care here in the Kansas City area. Throughout her career, Katie has sought to provide education that translates research and science into practical and useful techniques and to present topics in a down-to-earth manner that participants will find engaging and relevant to their own experiences. So with that, I'm going to turn it over to you, Katie, and thank you so much for being here today.
Thank you. I think I set myself up to set the bar high for myself. I hope that this can be relevant and meaningful and all those things today. We'll find out. We'll find out. But I was really glad to be able to have the opportunity to talk to you all about this. And as I was preparing for today, I was just telling Sherry, I was doing some literature review and research and found a couple of different concepts that were a little bit different way of looking at advanced planning that were helpful to me in my work. So I'm real excited to share those for you, with you all today. So today's session is called Remembering That Big Picture, Collaborative, Purposeful, and Informed Planning. And so we're going to kind of dive in and talk first about what is advanced care planning. And we're going to just start with a really basic kind of, this is probably what you all know, okay? The 3 kind of main areas, that medical power of attorney, financial power of attorney, and then code status or the living will. So the powers of attorney, those come into play when someone is not able to make their own decisions. Either it could be temporarily or it could be ongoing and permanent, but this is who you want to make your decisions for you if you can't speak for yourself, who you want to handle your finances if you can't do so yourself. And then code status, and I've kind of glommed this in with the living will thing, is we're really talking about an attempt to resuscitate via CPR, and then also other kinds of more aggressive medical treatments. Okay, so that's a lot right there. Those are kind of the 3 big things that we all talk about. These are all pieces of paper, and they can be put together in different constellations. Sometimes you'll see one big package that has all of it smushed in together. Other times you'll see somebody that has a medical power of attorney, but not a financial power of attorney. Or they may have a living will that says, these are kind of my overall desires, but they don't have that out of hospital DNR. So there's different pieces of paper, and we're not going to focus on those today, because again, what we're going to talk about is how do we fit these into our big picture, and how do these inform the big picture when we're planning, okay? So, we're going to start and talk a little bit about kind of, again, the easy things are that power of attorney. The out of hospital DNR, that's kind of a bigger thing. But then when that's are kind of the basics, the tip of the iceberg, there is a lot more that we could talk about. And I kind of geared some of these things toward ALS. Some of them, for example, the non-invasive ventilator, things like that are very much more specific to ALS than other kinds of disease processes. But truthfully, this is pretty relevant to any kind of chronic progressive disease, whether it's heart failure or liver failure or MS or dementia. We have so many elderly parents and people that are aging and are going to pass away from dementia. And so, again, I've tried to kind of fit this to ALS with some of these things, but this is pertinent to everybody unless we have a sudden accident and die quickly, right? At some point, we're going to be faced with some difficult decisions to make either for ourselves or with family members. So, big picture things that we look at are, do we want experimental treatments? Are we going to do physical therapy? Do we want tube feedings? Do we want IV antibiotics? What about all the doctor's appointments? All of the different things that may come into play at some time. That's a lot of different things that are kind of glommed into living will. And what I can tell you after reading probably hundreds of different kinds of living wills and advanced directives in my line of work is that they're not very specific. Typically you're going to have papers that are very broad and don't really answer these questions, which is fair, because these specific kinds of treatments or interventions are complicated, right? We can't cover all of this and every eventuality in one piece of paper. So that's where we're going to focus on today is how do we, yes, have those pieces of paper, that living will, that DNR, the power of attorney, for medical and financial, those are great starting places. But then how do we go beyond that to really have an informed, more robust advanced planning? Okay, so when we talk about it, advanced planning for the big picture, think about what is your big picture, because your big picture is probably going to have some things that are similar to mine, but it's not going to be exact, right? We're all different individuals. So, when we have a diagnosis, a serious diagnosis, I think it's human nature to start focusing in on that physical ailment and what are we going to do about it and the medical treatments. But we're much, much more than just our physical condition or our bodies. What is it that makes you you and helps you, enjoy life? What are your talents? And more specifically, how do you use those talents in the world? What do you give to other people? Who are your relationships and what are they like? What are your interests and passions? What do you do to pass the time? What brings you joy? Big things, little things. Are there big events coming up that are super important to you? There could be 1,000 different things under this. What is your big picture? But it's real important to kind of start identifying some of those and not get mired into viewing yourself only as a patient or only as someone living with a particular disease, right? So it's, think about this, your career, your vocation, your family, your loved ones, your hobbies, again, your home, your environment that you like to be in, that can be really important for a lot of us. What makes your home home? And again, don't forget about those milestones and big events in life. So what is your big picture? And then here's the real question. How do you blend your big picture with all this advanced planning? How do these things fit together? So let's talk about that a little bit. So when we talk about advanced care planning, sometimes we forget about one of the most important parts, which is the advanced part. Okay. Ideally, we're going to do this kind of care planning in advance with, before there's a crisis. And it's kind of human nature, I think, to look away and kind of put it off and not do this early enough. But the best part about advanced care planning is, again, doing it before there's a crisis. And then that way you can be collaborative and purposeful and informed in how you make your plan. So we're going to talk first about this collaborative piece. What do I mean when I talk about a collaborative advanced care plan? So this was something that was kind of interesting that I learned. I was looking at like, what are the barriers to people completing their advanced care planning, which is even just the paperwork. Okay, like that's in the most basic form. We're talking about those pieces of paper. And what I learned is that the last statistic I read was that only 25% of the general population have those papers in place. And even more shocking to me was that only about 25% of people with a chronic serious disease have those papers in place. So, you know, so then the question is why and how is it? What are we doing currently? How is it set up currently? And what do we need to do to change things to raise those numbers and make this a more effective process? And one of the areas that they identified was this idea of being and approaching this from an individual standpoint versus a relational standpoint. So currently, and it has been, our advanced care planning as we present it as medical professionals has been very much focused on individual autonomy. What is it that you as an individual want? What are you going to choose? What are your goals? And there's nothing wrong with that, right? But it's missing a big piece of who we are as human beings. None of us make these decisions in a vacuum. And so there's an idea that is called relational autonomy. And I think this makes a lot more sense, where as a person, we can choose to involve others in our decision making. So again, it's not just about what Katie wants or what Sherry wants. And it's really looking at how do we fit together with our loved ones? How do our choices affect them? And what do we need to hear from them or know from them that will, affect our decisions? We think about other people in almost every decision we make every day. I may be late for work and I really want to put the pedal down and go fast. And I'm like, oh, I better not do that. I might be putting other people at risk. Or even, oh, I might get a ticket and that's going to affect my family's finances if I have to pay a speeding ticket, right? So even very simple decisions like that are not made in this vacuum of what is it just for me personally that I want. So this relational autonomy is really what we're talking about in advanced care planning. And when we talk about that, it may be kind of like your next of kin, right? Your spouse, your partner, your children, your parent, those closest to you in terms of relationship. But it also might be somebody else. You may make a deliberate choice that, my husband is great with the finances. He's going to handle that part, but he is not good with this medical stuff. I'm going to have my sister help me with that. Okay. So your people, your people best. And it helps a lot to think about where's their skill set? Where do they shine? How do they fit into this? You don't have to necessarily choose someone to, make these decisions with you if they're not going to be a helpful participant. Some people just are not good at this, right? So know what each of their people can bring to the table and make this a deliberate, thoughtful choice of who you get involved. So when we think about a purposeful advanced planning, we think about purposeful advanced planning. This is really about, again, that big picture, who we are, what we want, what is important to us. And basically what this means about being purposeful in advanced planning is choosing interventions and making decisions, knowing that they're tools to get to an end result. So we don't want to get stuck in that trap of just accepting treatment, accepting interventions because, okay, this is just the next step in what you do, if it's not meeting the goal of your big picture. And I see that a lot as a palliative care social worker, and I had worked in a hospital previously to the time I worked with Ascend, and where it's really easy to kind of get sucked into the next appointment, the next test. This is what we're going to do next. We're going to send you to this specialist, and it really can become consuming to the point where we lose track of what's the purpose of this. And we're going to talk more about how we kind of manage that, but we want to be very purposeful in what we choose to engage in and in this advanced planning. We want our advanced planning to be informed, and what this is health literacy. And what I mean by health literacy is understanding the disease process, understanding what is a typical progression, and then also understanding and being reflective on what does your own experience look like. It's different for different people, right? But it also means knowing the benefits of different treatment options. Sherry and I were visiting a little bit before everybody hopped on about how sometimes when someone has a new diagnosis, their first inclination is, ugh, I'm not doing any of this stuff. It just sounds awful. I'm not doing any of it. And then when they sit with it a while, maybe they have some of that collaborative discussion with people important to them, they can kind of sit back and look, okay, there are some benefits to this. And again, it can really help. Some of these treatments and options can really be beneficial in allowing you to do those things that are important to you. If it allows you to be with your grandchild more, if it allows you to, enjoy certain things that you love, longer, then that certainly might be very big benefit. On the flip side, health literacy knows the burdens of treatment options. So, when you're offered a potential treatment, there is always going to be a trade-off. There's potential benefits and there's potential burdens or risks. And so health literacy is really understanding what are the benefits, the risks, and how do those fit into your own disease process and where you are in the trajectory of that disease process. Because something that you might choose early on may not be an effective choice for you a year from now or 2 years from now or 3 years from now. Things can change. So we have the basic stuff, and then we have, okay, we're going to do something with this, but we want to be collaborative, purposeful, informed. What does that look like? How do we really actually make that happen? And what does that mean in real world life? And it can be kind of confusing. And what I see is that it's really easy to get stuck. It's easy to kind of become in a place where you're just not really sure, or oftentimes, that 25%, we're lucky if we get them to even fill out a medical power of attorney or do the financial power of attorney. I mean, that's kind of the minimum, right? And there's a reason for that. There's a lot of barriers that keep people from really engaging in advanced care planning. So I've kind of narrowed down the barriers to 3 kind of general barriers. And the first barrier is folks living in the here and now, focusing on today. And what's really interesting about this to me is that this is actually of strength too. Living in the here and now is a very healthy, effective coping mechanism, right? If we all worried about what might happen down the road, or, what is going to happen down the road, or, you heard that, this happened to somebody else down the road, and you're just living out there somewhere projected in the future, you're going to just drive yourself crazy. It's depressing. It's not helpful. And you spin your wheels and, you know, it's not a useful way to live with a difficult disease. Not a good way to live in general, I don't think. So living in the here and the now is a really important coping mechanism. But if you only live in the here and now, that's a problem, right? Advanced care planning should be done in advance. So if you're only focused on today and you're not looking at what do you want for the future, you're going to find yourself in a crisis or just kind of going with the flow without really being deliberate about what it is you're doing. So compartmentalizing is really what we're talking about. It's a skill. It's, again, adaptive and maladaptive, where you can say, you know what, I'm going to focus here. And then I think that's fine. Focus on the here and now. That's important. That's how we get a lot of joy out of life, is to focus on the good things that are happening in front of us, but then also take time to say, okay, I'm also going to purposely plan for the future. I am going to look at what might happen and not just get stuck in either one of those. So other barriers, a lot to sort through. I threw up that, list of junk, vents and trachs and BiPAPs and G tubes and J tubes and, IV antibiotics and wound care and all those other things. And it's like, a lot of different, that's the short list. So there's a lot to sort through. It just really can become overwhelming, and it's easy just to kind of throw the towel in on the planning. The third barrier identified, not just by me, but in the literature, is that healthcare professionals typically are not good at this. We're not good at having these conversations about what happens in the future. Now, physicians in particular are great at talking about what we can do to try to fix things in the future. But advanced care planning is really difficult because we're talking about when things aren't fixable. We're talking about the time where things are not working. Our bodies are slowing down and different things may not be working for us anymore to keep our bodies going. And so physicians are trained, specialists are trained to focus on making it better, fixing it, rehabbing, turning the clock back, trying something else to extend life. And that's good. We want them to do that. We want them to be good at that. Unfortunately, they are not good at the other part, which is acknowledging the reality of caring for people whose disease trajectory is going to be terminal. And so as a society, we are terrible at talking about this. And in healthcare in general, we're not good at talking about this. Sometimes physicians or others are just not good at communicating in general. My mom had a hip replacement and had a surgeon whose bedside manner was lacking, but man, he was a great surgeon. That was okay. We're like, want those steady hands, and they're doing that surgery. But when you're really faced with a very serious disease, more than a hip replacement, that is a real barrier if they're not good at communicating with you. Time constraints, when you're there for a doctor's appointment, that's something in our healthcare system. They're booked up, aren't they? And they got to move, and that's really difficult. And then the other piece that was identified in the literature as being a massive barrier to patient-led, patient-driven advanced care planning is the physician's fears of not being unable to manage unrealistic expectations. And what I mean by that is that, again, they're in the business of finding solutions and fixing. And sometimes patients don't have a realistic expectation. So they have somebody that's coming in saying, my goal is to, go hiking in Colorado this summer. I want to go to the mountains and I want to hike. And yet they can see that they need all this oxygen and they're not breathing well and they're struggling to get around the house for their daily activities. that's a tough conversation and that's hard, you know? So they're human too. And I think that, you know, healthcare professionals are not good at having hard conversations. All right, so what do we do with this? So this practicalities, the looking at the big picture and the conversations was kind of cool. I pulled that after it was from a YouTube talk with, let me tell you who it is because it was really good. It was under My Support Study EU.eu. And it was Dr. Jenny Vandersteen, and she was really talking about relational autonomy and this idea of, you know, looking at advanced care planning as more than just paper and more than just an individual saying, well, I want this or I want that, kind of like picking things off a menu, but really talking about it as a process and not even just a one and done conversation. This is a series of conversations that we need to have as time passes, as we have a new understanding of our diagnosis, as we have different symptoms and even life changes. So what was kind of cool about this was she kind of pulled these three things out as kind of ways to have good, solid conversations about this or planning. And it really, big picture, we've talked about that, right? That big picture is, you know, our purposeful part. What is our purpose in choosing these interventions? How are they tools to get us to that big picture? The conversations, that collaborative piece that we're talking about. And then practicalities, that's really a piece of informed planning. So if you have a decision and you have conversations and you're engaging people, you're looking at them in tools, you're keeping in mind that big picture, and you're also learning about kind of the ins and outs and the nuts and bolts of things, like how do these things really work? That's real effective planning. And we're going to talk more about that. A little bit of piece by piece. I've kind of picked a few big ones to kind of give you an example. So one that we always talk about is code status. Okay, what is your code status? Do you want CPR? If your heart or your breathing stopped, would you want us to attempt to resuscitate? Okay, and this is a big old topic in and of itself. But again, it's not something that our medical professionals are good at talking about because they usually leave this as a yes or no question. And CPR is an intervention that can be a good tool for certain people. Unfortunately, it's kind of a weird thing to me that all of a sudden now it's become a yes or no, and the patient chooses this where we can't even choose an antibiotic. We can't even say, hey, I'm really sick for 3 weeks. Can I please have an antibiotic? But because this is not necessarily a simple yes or no question. Again, we're going to use our tool. We're going to look at health literacy. Okay. First of all, think about this in terms of disease process. Is your heart stopping a result of this chronic disease, or is it something else? You know, CPR was originally created and meant for young, otherwise healthy people who have like a sudden cardiac event that they can get it going again and then fix that problem and then move on with life. And somehow it's morphed into a treatment option for anybody, even very elderly, frail, old people at an end stage of life. And it's really contraindicated, you know. So what I mean by health literacy, know the disease process in terms of CPR is, if your disease is stopping your heart, then restarting it is not going to fix anything, or attempting to restart it is not going to fix anything. So the benefit of, you know, attempting resuscitation would be the idea of, hey, if there's even a tiny little slim chance that they might get me going again, I want to try that. The burdens of it are some, I mean, obviously, you know, if you've been to the hospital, it's kind of a I don't know, I don't like it. I think that they use this all the time about talk about how physically difficult it is. They're going to break your ribs. And it's true. You know, that's a horrible thing to undergo. Another burden might be that you end up in a machine. If you're somebody that's like, I don't want to live in a facility hooked up on machines where I can't go home and I can't move or do these things, then that is a significant burden that is very possible if, you know, you get the benefit of your heart restarting. Look at success rates. So we're talking about that. What is the likelihood of success? And then the other big picture is, this is big picture. How is it that you want to leave this world? And working in hospice, this is a conversation we have on the daily. It's in some ways a little tiny positive of a chronic terminal illness is that you do have an opportunity to plan and try to decide what is most important to you as you leave the world. Someone that chooses to be resuscitated is not allowed a natural death, and they're choosing not to engage in a natural death. And when I say natural death, what that usually looks like is family nearby, friends nearby, a home environment. We shoot for peaceful, calm, with symptoms managed, you know. So that's definitely a burden, you know, if you choose to attempt resuscitation, it's not going to be at home. You're going to be going by ambulance, lots of machines and tubes and medical professionals and your family. If they're there, it's not going to be pretty. It's not going to be something that they're going to want to remember. So that burden is also a piece of the relational autonomy. When we make choices about our health care and about what we want, we're also making choices for our loved ones. And what we do and what we choose impacts them. This is something that I think we lose sight of in our medical field and in talking about these conversations. If you really think about, you know, it's not just how do you want to leave the world, but how do you want your loved ones to experience your passing and your death? And I can tell you that it can be, death can be a very natural, beautiful event, a sacred event, a meaningful event, even though it's sad and very tragic sometimes. Or it can be a traumatic event. And when I say traumatic, I'm talking about the people that are left to live after the person dies. So that's definitely a potential burden with attempted resuscitation. Just real briefly talking about respiratory. This is a very common thing that folks with ALS are going to have to wrestle with. And so there's some, it's pretty cool. We have some real newer technology that can really help people live their big picture and can help them do the things that are important to them. And there are burdens involved with that, especially as the technology becomes more and more intense. So a cough assist, a BiPAP, non-invasive ventilators like a Trilogy, for example, all the way up to somebody that has to be on a ventilator with a trach. So, you know, you can kind of weigh out burdens, benefits, that sort of thing. But when I think the other thing that we miss are those sometimes the practicalities of what does that look like? And what does that mean for your everyday life? Oftentimes people that choose a trach are not able to live outside of a facility because it really requires 24-hour care, and it's more than the vast majority of families can handle. That's a practicality. You know, I've had folks that think and say, yeah, I want, you know, a Trilogy, and we provide those at Ascend Hospice. We feel like it can be a beneficial tool to help people with symptom management and to live as well as they can. So we provide those as part of our hospice service. But we also have folks that realize they're claustrophobic they can't stand having this mask on their face. It's not okay for them. That's a burden that for them is outweighing the benefit. And so then our job is to look at other options for managing those symptoms, because there's always other options. We can always figure out something. Um, those are just a few things I thought about, in terms of respiratory symptoms and managing those. So, you know, just kind of weighing that out, looking at your individual situation, your choices or your preferences, and um, just kind of the nuts and bolts of how something is going to work. Um, Feeding, okay? If you get to a point where you're not swallowing, you're not able to, swallow safely, it's going into your lungs. It's very common for folks to have feeding tubes and artificial nutrition, and it can be a way to, fuel your body. It's nutrition. It's fueling you to engage in those activities that are important, the big picture stuff, right? Unfortunately, there's the burdens, which can be infections of the tube site. Some folks have a lot of very intense diarrhea, which should not be too graphic. It can be very hard to manage, especially if you have limited mobility. And then that turns into its own set of challenges. The cost, for example, of managing all the supplies and someone to help you and all those things. What are the kind of nuts and bolts of, how do you get your feeding supplies, and how do you physically get the tube feeds in, and all of those kinds of things. And we have solutions for that. It's not that we don't have solutions, but what does that look like in your life? How does that affect your loved ones that are going to be there helping care for you? How does that affect where you are going to be able to live? And again, weighing all those things out is really what we're talking about in terms of a really solid advanced care plan. So here's the other thing about this. Again, it kind of goes back to what is your most important, what's your big picture. The other thing I did want to mention is that even though we talk a lot about, okay, we have this and this and this available to us, we also don't talk about what does that look like when they don't work anymore. So there's going to be a time where that trilogy that's helping you breathe isn't enough. There's going to be a time where feeding tubes, we can put the food in, but we cannot make the body absorb and process it. So there's going to be a time where the tools stop working. They're not effective. And that's the point where we really want to look at big picture. If your big picture is wanting to be at home as long as possible and, wanting to be with family, things like that, knowing when it's okay to stop using those tools is a big piece of that. And again, more conversations. It's not a one and done kind of thing. And it's not as simple as checking boxes on a form and signing your name, unfortunately. So we have help with that. The ALS Association obviously is amazing at helping do that information part, but also be a supportive, collaborative partner in your healthcare. At Ascend, we do both palliative care and hospice for our ALS patients. We have an ALS program that does a lot of things that people don't realize. We do tube feedings. We, do the trilogies, the non-invasive ventilators. We help people live as long as they can, comfortably as possible at home. And palliative care, so we have a nurse practitioner that can help really talk you through not just the kind of generals, but the specifics related to your own situation. So with that, I don't know if there are any questions or comments or discussion.
Wonderful. Well, thank you so much, Katie. And I do have a couple comments and questions of my own, but I want to remind people to go ahead and put some questions in the chat or the question and answer feature, and I'll be looking to those as well. So one of the things, just a couple comments, and then I've got some common questions I would get when I was working with individuals with ALS or their families. Um, so one thing when she's talking about the code discussion and the form that's often referred to as DNR or do not resuscitate. And I know when I worked in palliative care, uh, amongst us, we would much prefer this document to be called a AND, allow natural death, because in fact, um, when your heart stops or when your breathing stops, that is natural death. And like Katie referred to, the CPR that we're so used to or that we see on TV that is so inaccurate was really developed for those sudden heart events in a generally healthy person. And so we feel like sometimes that if we say we don't want those interventions, sometimes people equate that to like they're not doing enough or they're giving up. And that's not really true. You are allowing the natural process when that time comes. Um, so and it's really important as she's talking about all the different considerations. Again, my experience in palliative care in a hospital setting was really what it comes down to is talking with your loved ones on what matters to you, what's important, what is that thing that if I can no longer do this, that, or whatever, then I don't want interventions that will prolong things. So, so just some thoughts that really it's those conversations that matter so much. I've got a couple questions, but I'm going to start. Or did you want to add to those?
Oh, I was just going to say, I think that there's this, aside from, is this intervention a tool, good tool or not, or whatever, there's what I find is that there's a tipping point for every person where that the benefits are not outweighed by the burden. And it's that tipping point is really where they go, I'm not prolonging my living, I'm prolonging this dying process.
Very good way to put it. So let's take a couple questions from here and then I'll add a couple other ones. So we have one that, is there a similar organization to Ascend in St. Louis? And I don't know if you're aware, Katie, but our care service staff, the person who's asking that in that area, your care service coordinator or care service staff would be a good person to talk to as far as what are the hospices and palliative care companies out there that have been working with us that are like Ascend and have invested in truly understanding ALS and what palliative and hospice care looks like for someone with ALS. Because like Katie said, providing trilogies, taking someone on with feeding tubes is not typically normal in most hospital settings with other diseases. So it's very helpful to have a hospice who has an interest in supporting people with ALS. So, so definitely check with your care service person about what's available out there, what's the best resources. Then we have a question from like, when and how is hospice set up? Katie, you've worked with hospice for a long time. You've worked with palliative care and you've worked with ALS. How would you answer that question for her?
When I think about ALS in particular, I'll answer it from that standpoint. It really tends to begin when we're having more of a burden of disease, right? It's more symptoms, but also when you have certain things set up. Like, we want you to go ahead, if you think you're going to want a feeding tube, go ahead and get that done. We want you to go ahead and start that with your regular medical team and have that done ahead of time. Also, there's some kind of practical considerations like a power chair. If that's something that your insurance is going to pay for, they're not going to pay for it after you start hospice. So sometimes we have folks that are already in the process of getting those kinds of, a power chair or whatever, and we say, let's let you get through that process and then we can start hospice. Hospice is tailored to you. So it can be, sometimes we have folks that say, I just want maybe once a week. We always start twice a week. That's our baseline for nursing visits. But some people really are like, I want to stay as typical as possible, but they like that comfort of having that 24-hour on-call team, right? They don't want to go back to the hospital. They don't want to go to the ER. They like having that on-call team that we offer. And so that's one kind of, time that somebody can start, all the way up to where somebody really needs a lot more care. Maybe they're getting more wounds, or maybe, they're really struggling with respiratory symptoms and they need that care team that hospice provides in a more intense way. So help with bathing, help with, a social worker to help with the nuts and bolts and the emotional support. And, all the way we offer chaplains, and then we offer massage music, things like that. So it's really tailored to what each patient wants. So some people will start it sooner. People that wait and start it later usually say they wish they had started sooner.
And I will add to that my experience working with people living with ALS and their families. Those are what Katie's covered, are definitely some of the indicators. After those kind of major equipment pieces and things that you get, when you are at a point that going to the ER and doing some of those things is not quality of life for you, not something you want to engage in, hospice is wonderful. And I would encourage people, once they're eligible to, or even thinking if the burden of caring is getting harder, there's so many benefits to hospice, for you with care at home, for support for you, for support for the family, and for the whole person support, not just the medical support. So I often encourage people to, and you can have an informational interview. You can bring this up with your docs at clinic, or the social worker, or your care services person with the association, and just talk more about what is hospice, and talk through when might that be a helpful a helpful thing. So okay. Okay, we've got a couple things. I'm going to let you take this one too, Katie. They're asking kind of what are those eligibility requirements for somebody with ALS to,
Mhm.
engage in hospice?
Gosh, that's a really good question. And I think that, we can accept somebody at most stages of ALS. I mean, we're talking about you have a diagnosis and you're having some symptoms, We know that it's a progressive disease, and we know that people progress at different rates. So typically we kind of look at trajectory. I mean, this is not a really clear-cut answer. I understand that, but we're looking at somebody that's had a sharp decline, and they're really at a spot where they're like, um, like you said, I'm tired of going back to the hospital and, doing all the kinds of testing and retesting and going through the mill kind of thing. And they want to focus on symptom management at home. That's where really where we're at. Somebody that's plateaued and you're just steady and moving on and not a lot of change, um, you're probably not going to get a lot of benefit out of it at that point. So we really look at it, I think, from a big picture standpoint, not just where you are today, but how have things been going, and are you having changes?
Yeah, and I encourage you, don't hesitate at all to talk to anybody on your clinic team about that early in your process, later in your process, whenever that's on your mind, and your care services person as well, to help you kind of measure when is that something that you want to engage in, and what are the things you should consider. And you can always talk with a hospice company as well to kind of
Mhm.
understand where things are at. So
I will
um,
add too, the idea is that, a physician, two physicians have to certify and say that the majority of people with a certain condition and disease won't be alive in 6 months. Now, that doesn't mean that everybody passes away in 6 months. I mean, it's kind of like the bell curve. We have some that live a lot longer, some that live shorter. Most fall in there is kind of where we're trying to guess. That's the Medicare standard. But the truth is that especially with ALS, it's a disease process that's tricky. And so we do have people that are, um, tend to be on longer. Um, you have more than 6 month benefits. Some people think they only get 6 months of hospice and they don't want to use it up too soon. That's not how that works. We have people that can be on hospice longer than 6 months, or even people that go and they post and they plateau and they go off of hospice until they have another change, and then they can resume services again.
Okay, thank you. I'll just share one comment on here from someone who is on your services at Ascend and says she loves it and she loves all the
Oh,
aides and the nurses and your therapist.
that's
Um,
the best compliment.
mhm. And I have a question here about where in Indiana can somebody get it free advanced directive forms. And I will tell you that when I send out the recording later this week in an email to everyone who registered or attended, I will have some links on there to where you can get those kinds of things. But also don't hesitate to ask your care service staff that cares for you in that state with the association, or anybody at your clinic team can also help with those things. So you'll have multiple ways of getting connected with those forms. Let's see. Okay, we have a question. Who determines if you get hospice services? Can you speak to that a little bit,
Yeah.
Katie?
So your physician, could be primary care, could be neurologist, could be, whoever you're working with, writes an order. Um, and that basically certifies that they believe that you meet eligibility, criteria. And then our medical director and admit nurse and everything, we get all your records, we look it over, and our medical director is the second physician to certify and say, yes, we think that you qualify for hospice. I'll also mention we um, obviously work with a lot of Medicare, a lot of insurances. We do work with folks that don't have insurance as well. So, but we still go abide by those same guidelines regardless. Um, Somebody else asked about palliative care versus hospice. That's a great question. Our palliative care program is relatively new, and I think it's something that folks can get a lot of benefit from. We have our program. It's a community program, so our nurse practitioner comes to you, and it's based on needs. So, most of our people are seeing her about once a month, but if something's happening, she can usually come out within a business day or two. It's definitely not as quick and intense as hospice is. Our palliative care program is really meant to, for her to work with your physicians to kind of help make suggestions for symptom management, whether that's medication related or sometimes, just even in the house going, oh, hey, you've got this happening here. Maybe you should try this. That can be a different little um, view than if you're going into someone's office. Um, but again, it's much more limited. It's billed out under Part B, which means that it's like an outpatient service, and it's compatible with anything else you do. You can have home health. You can be going to the ER 10 times a week. I don't care with palliative care. With hospice, when you elect hospice, that's when you give up that more aggressive treatment, going to the ER, doing rehab, trying to, fix things, cure things. Whereas palliative care is compatible with all that.
Right. And palliative care frankly, my belief is that any person that gets diagnosed with ALS should have some involvement with somebody in palliative care, like the nurse, because hospice is a palliative care program. And what palliative care and hospice are all about is quality of life, managing symptoms, and looking at the whole person and the whole family. So when they're talking about managing symptoms, it's not just, am I having pain? Am I having some struggles with the drooling or the breathing? It is the psychological, the emotional, all the conflict, the grief. It's everything that's going on with you that is causing distress. So they have some ability to help address those kinds of things and really look at the whole person. Some of our clinics have palliative care in the clinics, or they have them, within their hospital systems that work with some of our ALS people. They are also very, very helpful as a resource if you're having difficulty having these conversations and kind of determining what is it that I want, understanding what it is, are your options, and just really having those conversations and helping you determine what you want at end of life. They are very skilled in those conversations. And as far as who determines getting hospice, basically hospice is a benefit that's available to everyone, regardless of your insurance, like Katie said. Hospice companies that take Medicare and Medicaid also, even if people don't have insurance, will provide services for them as well. And pretty much every other insurance has some type of hospital benefit. So it is something that is the standard of care for people that are in the end stages of their life, whatever the cause is. So I have a couple other things that have come up for me when I've worked with people as far as like, and you kind of address this, Katie, but just a little bit again, like I've gotten somebody maybe newly gotten their diagnosis with ALS. When should they have these conversations and fill out these documents?
I think the documents should be done early. Those are the easy ones, right? Like kind of,
Mm.
they're the basic things. And so if you start broad and then work your way more narrow, that tends to be a good way to attack it, I think. So in other words, the documents, those are pretty simple. Like they're not hard to fill out. They're very broad. They say, who do you want? Who is your partner? Who is it that you're going to partner with to talk these things through, to keep up to speed on what's happening, so that if something happens again temporarily or permanently, that you can't make decisions, they're going to be able to step in for you and do those things. So that's a big picture. That's easy, broad kind of intervention. And then once you at least get that piece hammered down, then you start really being deliberate in who else are you going to include in these conversations, and who else is going to be helpful for you. When are you going to have the conversations? It's different for everybody. Some people are very comfortable just kind of chit-chatting about it, and as during the course of normal day. For other people, it's much more difficult, and they kind of have to make a time, kind of force themselves to find a time and do it a little bit more formally. But certainly with different changes in the disease process, with decline, with a new diagnosis, with a new potential treatment option, those are all times that we want to make sure we're engaging with them. I think I went off on a rabbit trail. Did I answer your question?
I think so. And then there's another question here about, again, where do we get the documents? Who do we give them to? And
good question.
And
Yeah.
change them as needed. And
yes. So getting the documents, Sherry's going to send those out. Who do you give them to? Make copies. Make sure, take a copy and hand it to all of your doctors. Make sure they scan it into the file. I always tell people that advance directives are no good unless you have them in hand. If you have them, you stick them in your safe deposit box and nobody sees them, it's like you don't have one, right? It's not helpful unless it's present. I have one for myself and it's in the glove box of my car. But to me, that's a place that I know where it is. If I run into the doctor for something, I can pull it out if I need to, have them scan it into the system. And I've told my family that's where my paperwork is. For me, it makes sense. It's mobile. So you want it to be accessible. You want the person that's going to be the agent to definitely have it in hand. And then other people that may think they should be the agents, if that's the situation, make sure they know too. So for example, if you have 3 kids and that, Sally Sue is the one that is going to be first on the list, make sure the other kids understand that. That's going to avoid some burden and conflict down the road. And how can you change them as needed? Very simply, it's the most recent one is the one that is going to be utilized. So I have 2 pieces of paper in front of me. I'm looking at what is the most recent one, and it negates the previous one.
And that's an important point too. You do have the power to change these. Often you might do them early in your disease process and feel one way, and then that may change as you go one way or the other. And so you can change them. And another important thing is we're talking about that you're identifying somebody who can make decisions if you can't speak for yourself, That doesn't happen that often with ALS. As long as you can communicate in any manner what your wishes are, then you are still the one communicating. It's not like somebody's going to take over and make those decisions for you. And that's not what these documents are about. So,
Yeah,
um,
ALS is different. I mean, you talk about somebody with dementia, for example, somebody that's newly diagnosed with dementia or Alzheimer's, they can still have capacity to do these documents early in the disease process. That's very different for them because they know they're going to have an extended period of time where they can't make and communicate decisions. So that is something with ALS. It's a very good point.
one last question that I come across a lot or have experienced a lot is that whether it's the person living with ALS who is ready and wants to have conversations about this, not just documents, but conversations about what's important to them, that what matters now, what matters as they come to the end of their life, or maybe it's somebody in their family who wants to understand what the person with ALS wants, but one or the other party is really uncomfortable and keep shutting down those discussions. We don't need to talk about that now. That's not going to happen now, or something like that. Any advice for how you get those conversations started in either of those
Mhm.
situations when people aren't on the same page?
That's tough, isn't it?
Mhm.
Um, Sometimes when that happens, we talk about, is there an alternative person that can engage in this with you? Um, Sometimes those people are never going to be able to have that conversation. And so it's important for you to identify a care partner that can do that with you. Um, Another point, another way that you can draw them in is not necessarily to say, I want to talk about when things go really bad. Like, who wants to talk about that? But instead, talk about, I want to know what you want, what's important to you. And truthfully, that should be a part of our decision making is, you know, do you want to be present, at the time of my passing, if that's possible? Um, you know, how much information do you want to know? Um, and then the flip side of that is how much do they need to know? Somebody that's very saying, you're going to stay home as long as possible. I'm going to take care of you, but I don't want to talk about any of this. That's not reality, is it? It's not.
Yeah.
And so that's where you can also pull in third party folks like the ALS Association, your physicians, your palliative team or your hospice for sure. Um, it's complicated. It's messy, because you do have a whole constellation of relationships. It's not just a one and done thing.
Well, thank you so much, Katie, for being here and leading this discussion and sharing this information and your expertise today. And I can tell by the amount of questions and stuff that we are getting that this is something people really needed more information about. So just a reminder, this presentation is being recorded. So you will get an email from me later this week with this recording, as well as some other helpful resources, including how you go about finding the advanced planning documents that are good in your states. So, and definitely I will say one more thing that I want to normalize that having these kinds of discussions in our society is, you're not alone in that this being difficult. Death and dying is a taboo subject is still more than some others. And, a lot of people are uncomfortable talking about that, but it is a natural part of our lives and we're all going to face it. And there's so much more um, power in it, in having some choices and identifying, to the extent that we have the ability, what we want those things to look like. So again, I want to thank Katie again, and then remind you guys that a survey is going to pop up as you sign out, and I really appreciate you taking that. And I'd like to also ask, um, I'd really be curious if you have a minute to comment on, has this kind of discussion happened with your clinic teams or anyone else, or just any kind of feedback on, has it been conversational, or have you just been asked, do you have these documents? I'm really curious to kind of see what your experiences are with that. So I'd appreciate the checking the boxes on the survey. And if you have a minute to comment on that, I would appreciate that as well. And hopefully we'll see you guys again next month. So thank you so much for being here. And thank you, Katie.
Thank you. Take care.
Mhm.